All right. Well, again, thanks everyone for showing up. I hear it's supposed to be spring, but it certainly doesn't feel like it outside. But welcome. The topic for today is around our healthcare system and how it's mobilizing to support our new community members. But first, I would love to open the floor to Tracy, if there's any overarching updates you want to share with folks coming from the statewide perspective or the federal perspective, which I know there's a lot happening too.
Sure. Hi, everybody. Thanks a lot for having me join you again today. There aren't too many big updates, I think, that are affecting you right now. Overall, refugee arrivals have been low all across the country for the first couple of quarters. So it's not unique in Vermont that we're seeing low numbers. It's happening everywhere at about the same proportion. But now we're seeing a significant uptick, and we should expect that uptick to continue all the way through the fiscal year. So the numbers have doubled or tripled nationally in the last month, and we'll see that happening here probably as well. I don't know that we'll get to our target. I believe the target for the southern region is about 150, and the target for the kind of Chittenden and Rutland area is about 325. I don't know that we're going to get to either of those targets, but those are, and when I say target, I mean the capacity statement that we put in, not necessarily that has to be the goal, but that was kind of the capacity that we said as a state we could probably take. And just a reminder, as a lot of you know, that VRAP is winding down. That's the emergency rental assistance that a lot of people have relied on in Vermont, particularly lower income, including refugees. That is winding down. So lots of pressure to find housing, lots of pressure to get more people working as well. Homes that just have one person working will find it a strain for sure to have to be picking up rent. More people looking to combine and live together in housing. We're seeing that across the board as well. And then Ukrainians, we have plenty of Ukrainians still arriving. That number has slowed a little bit, but I think the number of applications that are approved for Vermont or that have been submitted for Vermont are about 160 to 170. But our Medicaid data tells us that there are about 60 or 70 people here. We anticipate there might be a few more than that because not everyone is probably engaging with Medicaid, but most are. So we're not sure exactly how many, but we know that there are sponsors out there. And then just a reminder that refugee resettlement agencies are still the major pathway. However, 2 new programs are live and online now in the United States. And one is the private sponsorship program called Welcome Corps. I don't think they have actually completed any sponsorships yet. The program is going to be going start matching people with applicants in April. The numbers will be pretty low this year. I'm not sure Vermont will necessarily get any matches this year. The phase 1 of the program is that sponsors can apply and they would be matched up with someone who has been really waiting for a long time to come here and has refugee status. So there would be no choosing your person. Phase 2, which they hoped to start 6 months after it begins, but I don't know that they will, is really meant to match people to specific people. So it is an opportunity to help people with family reunification. So if there are folks here who know somebody who is in the refugee pipeline, or families here who have families that are still, let's say, stuck in a refugee camp, that's another way to go. So that's the private sponsorship program, Welcome Corps. And the other program that's live now is the Cuban, Haitian, Nicaraguan, Venezuelan parole program, which is also a financial supporter program, kind of like a sponsored program. And for Cubans and Haitians, if they go through that program, again, somebody fills out a form online, names the person, the Cuban or Haitian, and then the person on the other end also fills out the form and names the person. If they are matched up, then they can arrive, and that supporter is meant to help them. They do commit to trying to financially support them, but Cubans and Haitians would be eligible for benefits just like a refugee would, and would also be eligible for the kinds of services, some of them, that resettlement agencies offer. Cubans and Venezuelans would not be eligible for any of that, but they would get 2 years of work. And we are hearing a little bit of interest there. We're hearing that some families are saying they've got a couple of Cubans coming, they've got a couple of Haitians coming. And so those folks would be encouraged to reach out to either ECDC or USCRI to be able to help get those services early on. When they first come, the sponsor would do some of the lifting at the beginning, but they would be eligible for some of those other services. I think that's probably it. You're going to talk about healthcare today, and just at the state level, one thing that we're noticing is not just for health, but because we have a lot more folks coming in now in different locations, not just the South, but now the Ukrainian program, you know, folks can show up anywhere. And eventually when the private sponsorship program gets going, Welcome Corps, they could also show up anywhere. We really have to think more about making sure that agencies, vital services are ready and able to serve people in the language that they need. And so that will be new and a big lift for some areas. Any organization that gets the Agency of Human Services money for essential services is meant to be able to provide in the language that is needed. All mental health agencies that receive federal money are meant to provide that, but many don't, because they don't normally get any clients who speak another language, except in certain areas. So more and more, we need to make sure people are ready for that, because we will see more people. Might be just a few, but we will see more people in areas that previously didn't. The same with the schools. There are some schools that are very functional and very good at serving people whose English is not their first language, or who have a refugee background and maybe have never had formal education, but there are a lot of schools who don't have that experience. And so that will be a little tricky as we get that on board. So I'm working with the Agency of Education to be a little bit more proactive about reaching out to schools and walking them through that process when people first arrive. All right, thank you.
Great. Thanks so much for that update. Next, I believe Jessica Rose, you are providing an update today for ECDC. Welcome.
Yep.
Thank you.
I can do that. Okay, so for right now, we have received 9 Eritreans, 3 families in total, 9 individuals. This is as of the fiscal year, so October 2022. The 1 family of 3 from Central African Republic, 1 Afghan single who ended up out migrating, and then a family of 3 Afghan who arrived the other day, and they are connected to people who already live in Vermont. So far we have 16 people who arrived out of our 100 in Brattleboro. And then we have 5 Eritreans coming at some point. We don't know when, 2 families, and 4 Afghans, 1 family and 2 singles. So 9 more will be arriving. I don't know when, but they're in the pipeline. So as of right now, we have 25 people out of our 100 in Brattleboro who have arrived for this year.
Great. Thank you. And I may have missed it, but can you say generally where the folks are arriving?
Arriving from?
No, what communities most of them are living in.
Oh, so we have the Eritrean population primarily going to Wilmington, and then the other families are in Brattleboro.
Great. Thank you so much.
Mm-hmm.
So next, I want to transition to the major topic around healthcare, healthcare services, and want to again start really at the high level. And again, as a reminder, these meetings are to remind everyone what we all do, what our various roles and responsibilities are as individuals, as partners. And so we have Allie Perline here from the State Refugee Coordinator's Office, who's their health coordinator, and we'll kind of start there and then work our way down to some local providers and hear from them as well. So thanks, Allie.
Sure. Happy to be here. Everyone, I'm Allie Perline, Refugee Health Coordinator, and as Alex said, I can kind of start and provide kind of that high level scope of work and reach. And then I'm really excited to have others here with us today that can really talk more about the on the ground local level work, which really drives all of this work and makes it all possible. So again, I'm the refugee health coordinator. So I work really closely with Tracy Dolan in the refugee office based in Central Office of Agency of Human Services. And so as health coordinator, of course, I carry to the work that healthcare and access lens. So my work, I have kind of two kind of key buckets of work. So one of which is really focused on new arrival medical screenings, which I'll talk just a tiny bit more in a minute. And then the other major bucket of work is really focusing on access to culturally and linguistically appropriate healthcare services, and to ensure that those services are available wherever the new arrivals might be located in the state. So circling back around just for a little bit of context real quick around the new refugee or new arrival medical screenings. So these are screenings that essentially all new refugees arriving to the state are federally required to complete this initial pretty comprehensive medical screening, ideally within 30 days of arrival to the state. There's a bit of a larger window there for some situations and circumstances, but ideally within the first 30 days. And it really has a heavy public health lens and framing. And so it's very much largely based on most current CDC guidance and screening guidance. And so depending on where that new arrival is from, their age, their gender, where they're coming from, there's just a whole series of various screenings that are recommended that person complete. And so again, because it's a very public health focused screening, there's a lot of screening for communicable disease. There's often lead screening for kiddos. There is very often or always TB screening, tuberculosis screening, most often for latent cases that are arriving to the state. And then a whole other array, again, depending on age, gender, et cetera. So from STI screenings and a whole kind of series of various related lab work that can go with that. So the other kind of element and purpose of that medical screening is that it really often serves as kind of that first point of contact for new arrivals in the state, being connected to Vermont's healthcare system. And so along with all those screenings that are done, it's also opportunity to ensure that folks are getting connected to primary care, that there are any other needed referrals or specialty care that folks are being connected to in a timely manner. And so it's really a pretty essential kind of jumping off point for folks. So in any case, that's kind of one key piece for very new arrivals to the state. And then the other bucket is really around this access to culturally and linguistically appropriate care. And so my work is really at a systems level, and rather than kind of that direct service, right? So my work is really focused around providing support when helpful to ensure that there are referral systems in place and workflows in place between resettlement agencies and the local healthcare provider networks, really just to ensure that, to ensure that those points of care and access to care are available, ready to go, and then to do any troubleshooting and support where it arises. As Tracy mentioned, of course, now our landscape of resettlement is drastically changing in Vermont, which is really, really exciting. And so there's a lot of need and opportunity to continue to ensure that we're identifying new partnerships with healthcare providers and partners and ensuring that folks are feeling ready and comfortable and able to provide care in ways that are culturally appropriate. So all of this work, of course, I look at it as it's the work, of course, is driven and made possible by the local level community partners, by the resettlement agencies, by the healthcare partners. And so I really look at my role as kind of that of a facilitator, is kind of how I view my work. So I can help connect partners with technical assistance, with best practices and working with refugees, best practices and supports in accessing interpretation services and best practices around providing care when you have an interpreter in the room with you, or whether it's remote in many cases for us. And then providing any needed connection for local level partners to a lot of the available state programs and services that are available. I know a lot of you are on this call today. Seeing Sue Graff, I'm seeing Chloe, which is the Brattleboro Local Health District Director. So I really serve as that connector where all of these local level folks are, of course, driving and making the work possible. So as just a couple of examples, I'll kind of wrap it up here, but just as a couple of examples of some of that coordination and connection to support. So I often do work very closely with the local offices of health. I would like to do a big shout out to Chloe as the Brattleboro District Director. I think of just one really wonderful example of really seeing this partnership budding between ECDC and the local health office. So taking no credit there, but being able to see all that work that's happening, that the local offices are able to provide vaccine clinics. I know that Chloe's office is doing a lot of work around wanting WIC services to be accessible and inclusive. And so there's a lot of really exciting work happening there. And again, offering things like vaccine clinics when there's an interest and need, and kind of serving as a point of contact for that local level public health connection and access to resources and programs. Another example around the healthcare access is being able to make connection to support our resettlement agencies in better understanding and navigating our wonderful world of Medicaid. That world is constantly shifting. Application processes and eligibility rules, right, as we all know, are constantly shifting. And so being able to serve as that connector to the Vermont Medicaid team, which has been doing a wonderful job in terms of being accessible to our resettlement agency partners and other community partners to ensure that we have our new arrivals being connected to healthcare in a really timely manner or as best as possible. And then finally, another element that really ties back actually to the medical screenings that are done for new arrivals is a lot of collaboration happens between myself and a number of our Vermont Department of Health programs, particularly those that are connected to our communicable disease, reportable disease program. So, you know, for example, we've seen a pretty common theme among our Afghan arrivals having pretty elevated lead levels. And so seeing that data come in and working with our lead program to connect to healthcare providers, providing that technical assistance to our providers, also ensuring that any outreach that program is doing to folks for follow-up is being done in a way that's culturally and linguistically appropriate. So there's a lot of kind of points of contact that I have connecting local level partners with our state level partners to ensure that our new arrivals are, at least to the best of our ability, accessing healthcare services. But as I said, to really, I don't want to take any of the credit that happens on the ground. It's, I'm just so grateful to constantly be able to work with all the folks that are at the local level, really doing this work and connecting folks to the services and care that they need. So I think I'll pause there. I'm happy to answer any questions, but definitely want to leave plenty of time for some of our local community partners to share some of the work that they're doing.
Any questions on the big picture? Great. And so let's zoom in a little bit more and hear from some folks on the ground. I know, unfortunately, I did not ask you to prepare anything, but Chloe, as a local coordinator, if you want to chime in, you know, there's plenty of time in the agenda, or we can move on to our partners at ECDC.
I don't have anything specific. I mean, what Ali covered is a big part of our work, trying to make sure that we can get folks vaccinated. WIC has been a big project, as all of our new arrivals can qualify for WIC. So we want to make sure that our resources are quality and translated. That's been kind of a work in progress. There's some improvements I think that we can make at the state level that I'm really working on for this group. But we want to continue partnering in grocery store tours, doing lunch and learns at ECDC's multicultural center site. So that is a big priority for us, is to make sure that WIC is accessible and easy to use for this population. So that's kind of a ongoing and continued project. And then also wanting to kind of bridge the gap with dental care. So we're hoping to be able to start a couple pilot projects that's still kind of in discussion right now, but to improve access to dental care. That's been such a difficult thing in the Brattleboro area. So we're hoping that we can kind of get some things in place to better reach this population and the dental care side of things as well. So that's still early days there, but that's a big goal for our office as well. And Allie, thanks for the shout out. Appreciate all of your continued work and partnership for this community. It's awesome. And ECDC, of course, you all are fantastic humans.
Thanks so much, Chloe. It's been wonderful being able to work together. And sorry to put you on the spot.
Yeah.
Not at all. Thank you.
Yeah. Thanks so much. And I think that's a great segue to hear from our partners at ECDC. Camilla, thanks for joining.
Good morning. I was asked to put together a little presentation, so bear with me.
Yeah, let me, thank you.
Can you hear me?
Yes, yeah, if you have something to share, you should be able to share now.
Okay, let me know if this works. Wait a minute. Can you see my screen?
Yep, but the slideshow is kind of off to the side. There we go.
Yeah,
Perfect.
we're gonna get that figured out.
Beautiful.
All right, is that working?
Yep, we see your presenter view, if that's okay. Before it was more, but
Well, that's not supposed to happen. Let me get out of that then. Okay. Is that still the presenter view?
if you try from the beginning, if you click present and then you may just not have your notes. Is the problem. There we go. That looks good to us.
But I don't see my notes.
No.
Okay, so Eduardo just came and got rid of my notes. So I'm gonna have to wing it a little bit. So my name is Camilla Tarmy, and I'm the health navigator at ECDC here in Brattleboro. Much of what I intended to say today was covered by Allie and also Chloe. So I'm sorry if it's a little repetitive. I will try to limit that. Core services that we provide here are first the domestic health assessment. Again, Allie touched on this. It's somewhat of a challenge to find providers who can do this. Currently, we are looking to a clinic in Bennington that does great help seeing adults, and the children are going to Dartmouth Hitchcock for their pediatric DHA appointments. We also enroll everybody in Medicaid upon arrival, and everyone is initially eligible for Medicaid. We're very aware of the upcoming Medicaid unwind that is a change in the COVID era policy. This will certainly impact some of our clients, and we will do everything possible to ensure that they continue to have health coverage, health insurance when those changes happen. Clients are referred to a PCP, and here in Brattleboro that goes through the centralized scheduling at BMH. They've done a fabulous job, and some of the new providers have really done amazing work with our clients, providing that culturally appropriate care as much as possible, working with translation systems. This is not easy, we all know, and I really am so encouraged to see the kind of effort and willingness that they put forth to help our patients. Part of what we look to do is address the emotional health of clients. This is certainly a little bit more challenging to identify and support because of those cultural and linguistic differences. We're fortunate to have partnership with HCRS, who is working on this. They currently also have a presence at the Multicultural Center, where there are people there who are available and trying to do some reach out and help support folks as they work on this part of the difficult transition process to building a life here. There's also UCS in Bennington that is addressing some of these needs. This is a certainly more challenging part of what we aim to do, and we are very grateful for the support we're getting from other organizations. Dental care was talked about by Chloe. We're super fortunate to have a partnership with the United Way of Windham County, who secured a grant to pay for dental care for our clients. And Sarah Pugh at the United Way has just done a phenomenal job in finding appointments and paying for that care that is very essential for a lot of people coming in who haven't had that opportunity to see a dentist. And certainly in our community, where most dentists are not accepting new clients, cannot accept new clients, and or don't accept Medicaid, she's really done an amazing job in helping in this area. And we certainly hope that the grant can be renewed in the future. Education is certainly a big piece of what needs to happen. A lot of room for improvement. Ali talked about this, and I won't sort of repeat how important it is to find the culturally appropriate information, practices, expectations when our clients have interactions with our health system. It can be baffling, it can be scary, and we need to really do everything possible to facilitate that process and develop good relationships between clients and providers. It's a reach, it's a additional work for providers to do this, and we so appreciate that they are willing to do that and help in this process. An initial piece of educating clients about our system is part of the cultural orientation that SIT, School for International Training, does here upon arrival of our incoming refugees. Certainly, in addition, what I wrote here, in addition to providers, co-sponsors, volunteers, everybody who works with our clients benefit from knowing more about where folks are coming from, what they're used to, and how we can help them make that shift here as they're dealing with any sort of medical or mental health issues. In addition to the more sort of clinical pieces of what we do, we're really looking at how we can include health promotion activities in a more general sense. And it's been great working with the Multicultural Center to do this, trying to organize activities, gatherings, and to do this, we've had some events with WIC. Winston Prouty has nurses who do home visits, have been phenomenal in their support of certainly mothers with young children. EES currently applied for and received a grant basically on our behalf, which is amazing. Thank you, Sandy. We recently also had a meeting with providers who are connected with the perinatal support here in Brattleboro. And it's just so encouraging to see how many people are dedicated and determined to reach out and help women in a really important part, exciting and potentially difficult part of their birthing system. So trying to get women to come to the center for more sort of education and support is something we look forward to doing, and working with Jill at the center has been been great. Thank you. School counseling offices are a resource that we need to be more in touch with. We know that there's some students that struggle, certainly. And also we would like to connect families with the experience of their students in school. That's something that's, for the most part, not something that's common where folks are coming from. So again, getting people involved, being together, discussing and learning. Activities that look just at how to connect with the community, looking at overall wellness, well-being is certainly a goal. And to that end, trying to organize excursions. What can we do in the community? Skating, bowling, picnics, swimming, how to have fun, how to be just emotionally healthy, and trying to enjoy what this area has to offer, what we other people have to offer. And that's definitely the overriding goal of everything this office does. And this office doesn't do it alone. So thank you to everybody who makes our work possible and goes the extra piece to reach out and meet people where they're at and where they're coming from. I also want to recognize, before I wrap up here, that the Bennington office has done a fabulous work, really hard work there. Jack and Megan and their volunteers and supporters there have done a lot of this on their own, and we're really aware that more connection from our end and working together with you all is important. So with that, if there are any comments or questions, happy to hear them.
So there is just one questions in the chat around the work being done in Bennington County. It sounds like a lot of the similar activities are being started or are up and running in Bennington. If you want to provide a little more info on that.
Yeah, that's certainly the goal. Bennington has just recently officially opened an office. So they have, they've been working on developing more of an infrastructure and a presence, and all of that programming that I've talked about that we're working to provide in this area certainly is, we have the same goals for Bennington. It's just, it has started a little bit later.
Great. And I saw another hand up. I don't see it anymore, but if anyone.
It was me. I apologize.
Yep,
We
go
had
ahead.
it's Judith, and we had a brief disconnection. So someone may have already spoken to it because we had an interim of no service for a hot minute. But I just wanted to note that ECDC is doing amazing, and that Camilla and team, that they were over at the Bennington office, and Lena Samadi and myself, we were able to join them on Friday. And it was really nice to see the different meetings being held and seeing some of the folks who are working in the community there. So just a shout out to the two offices and the coordination, which of course is ongoing, and learning how to work with folks in a different region. But I thought they did a wonderful job, and it was really fun to be present for that day. Thanks.
Great. And I'll echo another comment in the chat with kudos again to the ECDC staff around childcare and early intervention support for families in the Valley, which every week we have a different topic, but the one thing that stays the same is that there's ECDC staff making sure everything's connected and done and being followed through on at the end of the day. So I think, big thanks for all of that.
If I can just add one more thing too, we recognize that there's limited capacity with our local providers, and there is an effort to look further afield to Townsend, Grace Cottage Hospital, and also perhaps to North Adams, where there's some possible providers that can see some of our clients. People have experience with working with international patients and refugees specifically. So we are always looking for other places and people that can work with us. It's a lot.
Great. Thank you. Sue.
I put my hand down, but I didn't unmute. It's hard to do two things at once. Sorry. I'm Sue Graff with the Agency of Human Services, Field Director for Brattleboro and Springfield. It's great to hear this conversation, and thank you all for your work. Because it's complicated, so Camilla, kind of piggybacking what you just said, and knowing, as we said earlier, that, you know, really resettlement is happening all over, I do wonder, and I'm just curious if there are smaller convenings in the health space of all these providers to really understand best practice and share. Like, I'm even thinking about like Boost Lingo, like who's using what interpretation services, and knowing that that's a challenge. Are there places where you're bringing, and this isn't necessarily to Camilla, this is really to Ali and other providers. I'm curious about the role of BMH in this space. So I just am not aware. And so I'm curious, are there, you know, kind of smaller conversations where some of this kind of resource sharing happens so that we're kind of staying on the same page, especially given the breadth of, you know, all the health, you know, the kind of holistic approach that you're taking, which is great, knowing that mental health is embedded like in the Children's Integrated Services System, for instance. So how do we make sure that CIS providers have access to interpretation services? And, you know, it's sort of all connected. And I know we're learning and growing as we go, but I'm just curious how much effort is being done to kind of make sure folks are on the same page or sharing resources kind of on the ground day in and day out. I imagine that's happening informally. I'm just curious about any sort of formal.
Before I arrived, which was last July, ECDC was using an interpretation service called Boost Lingo, having found that this is very effective among the many options, and very fortunate that the whole BMH system adopted the same program. So though Boost Lingo is available for all of those appointments, it's now available in Bennington as well. All ECDC employees also have this on our phones. It's challenging. We've been obviously fortunate that among our Afghan community, there are individuals, like people who can do some of the translating. With our newer arrivals, that's not possible yet. So that is certainly going to be challenging. The office here is getting our own tablets that we can also send, that will have Boost Lingo, that can be sent with say volunteers who are taking someone to an appointment, so that they can also interact with them. So that's as much as really we have available for translation to address the
Alex,
smaller working. Sorry.
well, maybe it just makes sense for me to chime in here.
Yeah.
I have a bit of this piece. And
Yes, yeah. So our last
covering.
person. Yeah.
Yeah.
And Gina, if you want to talk, and then maybe that we can kind of end with how everything kind of comes together and stays together as our networks grow. So yeah, Gina, go ahead, and then we'll do more questions after.
Okay. Karen, is that okay for me to go, and maybe I'll answer a question that you might have? Is that okay? Okay. So I'm Gina Pattison. My title says nothing about working with people that are coming to our community. I'm actually Director of Marketing and Development here at the hospital, but we had our Diversity, Equity, and Inclusion Director left about a year ago, I guess now, and so I was asked to step in this role. So that's why I have a title that doesn't really fit, but am happy to have been working really closely with ECDC and with Ali at the state level to welcome these new community members and try to get them set up with the proper health care. So I'll start by saying that it was really challenging in the beginning with so many people arriving to our community at the same time and not having had this experience before. And so we were all really learning together on how we were going to get people into the healthcare system that spoke a different language and had different cultural backgrounds and all of that. So appreciate the partnership that we've had. And that would be one of my first things that I would say when I think about Bennington, and if there's any help that BMH or that I can provide, is it's so critical to have a relationship with ECDC and with the state. We have been meeting weekly by Zoom to make sure that we're all on the same page, and are there certain situations that a BMH needs to be made aware of, vice versa, or just general topics. The interpreter service is a really good example of that. We were using a language, an interpretation system that really was not efficient and was not meeting the expectations of our staff or our clients or our patients. And so working with ECDC and hearing that they were using Boost Lingo, I did a lot of research and it came down to that Boost Lingo really was the best option for us at the time. It's the most, it's just a really easy system to use. So my first thing I would say is, from the healthcare perspective, is forming those relationships was really key to being able to see as many patients and have that process be as streamlined as possible. So we worked with ECDC to set up a process where when new, it was all Afghan refugees at the time arrived, that they would reach out to us. We'd provide them with the paperwork for new patients, and they would get that paperwork filled out and into our centralized scheduling department, who would then set up appointments, their first appointments for these new patients. The really challenging part, I think, was the DHAs, the domestic health assessments that have been, we've talked about a couple of times here. As I'm sure everyone knows, finding BMH is definitely, like all other hospitals across the country, primary care clinicians are not abundant in our area at this time. And so we really did our best to be able to bring on another clinician that worked specifically with doing the DHAs. That was really helpful if that's an option for people to be able to do. I would say that was really great to get us started. Unfortunately, that clinician then left and went abroad, and so we lost those services, and we were trying to put them into with our primary care clinicians in their first appointments. The problem is that it's not easy to get new patients in within 30 days to get those DHAs, and as Ali mentioned, that's the goal, is to get them those DHAs done in 30 days. I think we got an extension to 60 days, Ali, at one point, and so we were definitely having to utilize that. And now working with the Greater Bennington Clinic has been really helpful, where they're able to do a lot of the DHAs, that the patients are getting their lab work done. And so we have that relationship now, where I'm working really closely with that clinic to make sure that lab work is being turned around and they're getting that paperwork that they need. So I would encourage it. One of the things that Alex had said to me is, if somebody was new into this this realm, whether you're working with an ECDC or you're working, a similar agency, what were some of the things that worked and that I would want to share? And I would say having a hospital liaison person is really important to be able to have to establish those relationships, have regular meetings with them, be able to share any concerns or challenges or things that are working, so that liaison can then share that with the hospital staff and improve on the processes that need improving on. Develop the process for new patients, make sure you know what that process would be, and that in this case we know that ECDC knows to reach out and get the new patient paperwork that would then go to centralized scheduling, and then the process starts from there. Important to get that paperwork in as soon as possible because of the time it takes sometimes to get a first appointment. One thing that we developed not too long ago that actually one of our staff members suggested is to create appointment cards that are translated into Dari and Pashto. We were noticing that we were having a lot of missed appointments by the Afghan the population, and I think that wasn't intentional by any means. I think it was, it goes to the language barriers and making sure that the clinician is saying to the interpreter, this is when the next appointment is, but then writing it down on an appointment card that is in English, it wasn't working. And that makes sense when you say it like that. It took us a little time to get there. And so hopefully those kinds of little things make a big difference. ECDC's done a really great job at working with us on who the health contacts are for these patients. And so that's like the sponsor. I call them health contact, but I think ECDC really refers to them kind of as their sponsor, and having those sponsors fill out a release of information form so that we can communicate, verbally communicate with the health contact. They might be the person that we call to remind about an appointment coming up. They might be the person that we reach out to say the pharmacy, called and said that this prescription is still sitting there and they need to make sure this gets picked up for the patient. So having families have a health contact has been really helpful. We can't insist that they have a contact if the family can, speak enough English or feels like they can navigate the healthcare system on their own. That's wonderful. That's the goal, right? That's what we're hoping for. But there are many cases where these patients need a little extra assistance. And so having a health contact that signs a release of information and having that on file has really been very, very helpful for us. The other thing I'd say is that, I don't think that we did a great job in the very beginning of training the staff. And like I said, I think a lot of that has to do with the fact that we were receiving new patients fast and furious, and we didn't have a good process in place. Now we have the Boost Lingo translation, and so I do that training with all of our frontline staff. And basically what it is we have iPads all over the hospital with just the Boost Lingo app available on it. And so when a patient walks into the hospital, we have screeners now, thank you to the pandemic. So when they come into the screeners will start the Boost, they'll give them an iPad, we'll start the Boost Lingo application, and the person will take the iPad with them to their appointment. So they have the iPad from the moment they walk in the door to the moment they leave, when they will leave the iPad with our screeners. That works really well. There are some situations where we might not know that the person needs an iPad and needs a translation. This Boost Lingo, by the way, is not just Afghan, not just Dari and Pashto. It's hundreds of languages. So we have many Spanish speaking and Chinese speaking that we use that all the time. If we aren't aware that when they walk in that might be necessary to use the interpreter service and they end up going up to their appointment, the practices also have the iPad available so that when they are in the exam room with the clinician, they'll just call up the interpreter at that time. There are some challenges to that, right? We don't have wonderful Wi-Fi all the time in our area, and in our old parts of the hospital, that's even a little bit harder. So there are some challenges, but I would say 90% of the time it works really well, and we've had really great response from both the health contacts and the patients as well as the staff. I think that Allie's been a really great resource in terms of the cultural differences. I think that we could have probably done a better job in the beginning. I think this has evolved over time, but really kind of training staff about the differences, knowing that, for example, with the Afghan population, that the women only want to see women clinicians. And making sure that we can do that. Now, this does come into, if you go into the emergency room, it's not always going to be the case. And so how do we set those expectations with patients from the very beginning? And this has been an evolving process for us, really trying to figure out what's the best way to communicate that it might be that your anesthesiologist is a male. Those are really challenging, but it's super obviously important information to get across and to communicate with the patients. I think I'll stop there. I'll stop there and see if there are questions. I don't know if there are others that are speaking. I don't want to take up too much time. Yeah, Karen. Oh, you're on mute.
Sorry, just to pick up on your release of medical information point. We found that a lot of the time as people are settling in, they have a lot of questions about their health and about what's an emergency and what's not, the sort of triage function. And on our core team, we have on the health team, I'm a physician and we have also an oral hygienist. So we're sort of better able to help assess what needs to get referred right away and maybe what doesn't. And we know that's really more of an ECDC role, but it comes up all the time in ways that we have to kind of deal. So what I'm wondering is, could it be that the release of medical records be very routine as a question early on? Because in our case, we sort of didn't tweak to it till pretty late. And now we do have it, which is extremely helpful for us to be knowledgeable and then coordinate way better than when the person said, I can't hear and I have an earache. You know, was it chronic, was it acute, so forth. So that was my suggestion, was to, if possible, of course, have health providers on the core team, for the health core team. That's really helpful. But secondly, to do the medical release form more routinely earlier on.
So Karen, I think just to understand, are you talking about the release of medical records or medical? Because the form that we have, the health contact sign, is the release of medical information, which basically means that we can have verbal communication with the health contact. Like I said, that we might remind them about appointments, or that the pharmacy is picked up, or what have you. But the medical records is a good point. We don't make that standard practice. I don't believe, Camilla, you might know differently, but I don't think that that's part of that packet. And so you're suggesting that we have that form available also?
Yes, because first of all, I didn't even know about the medical contact thing. Nobody's mentioned that to us.
Okay.
But because we did have these emerging problems with need for early intervention with the Prouty Center and with other issues very early on, then we, at the time of the appointments that were made, we would ask the provider, could they get the medical release form signed when the family was there? So there's nothing kind of in the protocols about that. And so I'm suggesting it would be really helpful if it were.
Okay, thank you.
Great. And Judith, yeah.
Yes, thank you. To piggyback on that, I know in some other scenarios, largely around housing, there are some forms where different agencies are listed. It's a release that folks sign, and it's more on that verbal stuff, not so much, certainly not medical things being shared, but being able to talk with different organizations. And I wondered, so it might be at a systems level, but I wonder if we could potentially have something like that set up that had a number of agencies on it. As an example, sometimes with HCRS being a referral that might want to be made. And if, families had signed something that allowed that communication, it might be easier. So I just think that, and of course we're doing them ourselves, but it might be helpful if on a larger scale, we were thinking about the variety of the agencies that are working with folks. And if we had, I don't want to say it's not a generic release form, but something that had more than, the one or two providers on it. And I'm not sure where
each organization has to have their, for HIPAA privacy concerns, each organization would have to have their own. But I believe that a healthcare provider can provide that referral and have that conversation with who they provide the referral to. So if they were providing a referral to HCRS example, then they can have that conversation.
Sure.
But I don't know. I will look into it. I just don't know that it's possible to have a standard form that would sign and cover multiple
Sure. Sue Graff, if you're still on, I can't see you at the moment, but I'm sure you know what I'm referencing since we've had it in a number of spots. So I wonder how that had came about, or I see Tracy's hand up, so I defer to whomever.
And Judith, I would just say it's the difference is the HIPAA requirements. So I think there's a difference between a joint release of information for other information versus health information and certainly mental health information. So I think, there are additional challenges to some of that sharing, but it's certainly worth looking into. So, and it looks like other folks have.
Yeah, Tracy.
Sure, I would say, I think this is a great discussion around the difference between a health contact, meaning this is a release so that I can let you know when there's appointments, versus this is a release so that you can take on some possible medical decision making. I think that would be a really good discussion to have and really figure that out. One of the things ECDC has been trying to do is to get real clarity between the difference of a role in a sponsor versus staff, in part because it can feel like it can be tricky with a great deal of responsibility. Medical providers tend to start speaking directly to sponsors at times, especially in appointments, and sometimes lose the focus on the client if the client doesn't speak English as their first language, et cetera. So I think and maybe it's not even a one size fits all, but I think this would be a great systems level discussion to have that I bet Allie could head up, and we might get a little bit of help on our side and a little bit of help on DC sides too, to just figure out what that role is and then connect with health agencies too. So I think it might be a slightly bigger conversation that's probably not a quick, we'll add people here and there, but probably a systems level conversation.
Good.
But I can certainly see the need for kind of the quick information. And I recognize that different sponsors have different qualifications. So we'll have to think through when does that therefore shift kind of the role. That's what I'd recommend anyway for ECDC. And I think Allie could probably help out with that conversation.
Great. Thank you. Grace.
Tracy, thank you for that comment. That was something that we've been struggling with in Bennington. Also, if the providers do talk to at first, they talk to just the volunteers with the interpreter happening, being the communication with the client. And we have had to deliberately pull back from that. But I still send our volunteers into the room because a lot of times there's confusion about what the provider said. And if there's no witness to that, we have no way of getting the information without some difficulty. But I wanted to say thank you for the idea, Gina, about sending the interpretation tablet with the patient from the door. I will recommend that to the provider I work with, UCS. But I also wonder if you have a direct line to SVMC, because at SVMC, if you go to the lab or you go to the emergency room, you have to be able to tell them who you are, why you're there, what your date of birth is, what your address is, before they will get the interpretation service for you. And I would love it if we could accomplish all of that right at the door. But do you have a contact at SVMC that you could maybe share that information with?
I do not, but remind me, Allie, there was a woman that was covering the health office, the Department of Health from over there. Is it
Megan Harrington? Yeah.
So
she has some connections.
Connect with Megan.
Yeah.
Because I think she has the contact at SVMC when she was participating in our weekly calls for a while that we were having with ECDC. And so I'd be happy to reach out to her and see if I can help to facilitate some sort of a conversation with SVMC.
That would be great. Thank you.
Sure.
Great. So we are almost at time, but one thing, and first and foremost, thank you to everyone involved in a very complicated system and in a very important one, of course. I think both physical and mental health should often be the top priority as folks arrive. And so thank you to everyone doing this work. The other thing I want to mention is the incredible work that our health justice and equity groups are doing in our region and across the state. I did see Candace on the line at one point, who does this work with United Way, but generally speaking, there are a number of folks who are looking at not just, at the surface level of how diverse populations engage with our healthcare system. And so they take both the approach of improving services to folks with diverse backgrounds, which is really excellent. And also what I know, at least, BMH and HCRS have really been leaning into is our diverse workforce development group. So we also in Brattleboro host a diverse workforce development committee that really focuses on making workplaces more welcoming to folks of diverse backgrounds. And in health careers, particularly, we know that if there's someone on staff who can make those connections directly and personally, that's better than a translation app. generally speaking. And so there's both the short-term solutions and then there's the long-term solutions, which are making our healthcare providers and our healthcare systems look more like the people we're serving. And both of this work is being done, I think, really well and seriously in our community. And so folks interested in that, from an employer perspective, that's the Diverse Workforce Development Committee. But again, United Way and the NAACP and Sue's group talk about this often, that how do we meet the needs of a diverse population, and they're, from a variety of different perspectives. So I do just want to highlight their work and the underpinning of how we all learn to do things differently and serve folks better. Any questions or comments? Again, this was a fantastic meeting. I think, anyone with healthcare questions can watch the video, and I think they'll all be answered one way or the other, which is always my goal. But just the sheer number of partners who have, dedicated their days to making this work is great. So if we don't have any last questions or comments, thanks a lot. Feel free, folks, to send me an idea for what the topic for next meeting might be. I think I see Emmett. I think financial literacy is going to be on the list. I know you're starting a nice, exciting new project, and that's launching as well. But anything else that you folks might want to cover, shoot me an email. We'll get it on the agenda, and we'll, I'll see you in a month. So, thanks, everyone.
Thanks.
Thank you.
Thank you.